السلام عليكم.
عليكم السلام.
عليكم السلام.
Good afternoon, everyone. Welcome to our academic activity for today. So today we have 3 lectures. First one is about ventricular septal defect, will be presented by Dr. Abdullah Shahri. The second lecture will be about total anomalous pulmonary venous drainage by Dr. Hammam al-Bishar, and will end up by a journal club, will be presented by Dr. Muhammad Babki. We are pleased today to have Dr. Atizaz Dean, who's a cardiac surgeon from Medina Cardiac Center, as our guest for this session. So we'll start in 5 minutes, inshallah. Dr. Abdullah, you can prepare your slides. Thank you.
السلام عليكم.
وعليكم السلام ورحمة الله.
Thank you. Abdullah?
Yes.
So Dr. Atizaz is with us or still need to join?
He confirmed for me early morning. I tried to message him now, but he did not respond yet.
So we can wait for a few minutes.
Yeah.
See.
Okay.
So you can start once he joins.
Okay, sure.
Thank you. So apparently Dr. Atizaz is engaged in an emergency in the OR, so we'll just see if Dr. Matthew is around to join us and then we can start.
If he's not there and you want to start, you may go ahead.
Abdullah?
Yes, Doctor.
تفضل, you can start.
Okay. Okay, Bismillah ar-Rahman ar-Rahim. Good evening, everyone. We will talk today about ventricoseptal defects. I'm Abdullah Shehri. The outline of our presentation today is the anatomy, morphological classification of this VSD, and pathophysiology, clinical presentation of the patient, most important investigation, and the surgical approach. Okay, first, the VSD or ventricoseptal defects is an abnormal opening or the defect in ventricular septum, which either to be part of the membranous septum or in the inlet or trabecular or in the outlet part of the septum. It's considered one, most common congenital heart defects, representing approximately 1 in each 100 live pairs and 25% of all congenital heart defect. This is an illustration of the normal ventricular septum, and this view is from the right side of the heart after dissection of the parietal ventricular wall. As we can see, this is the inlet part of the ventricular septum. This is the trabecular or muscular part, and this is the outlet part, and this here will be the membranous part. This yellow circular structure here is the atrioventricular components of the membranous septum, and the one is inferior in the with the light blue color is the interventricular components of the membranous septum, and this is the AV node in the triangle of Koch, and this is the conduction or bundle of Hess, which is running in the ventricular septum just near to the one of the most common defect with the VSD, perimembranous. And as we can also see, this is the septal band of the papillary muscle, which is coursing from apex of the heart, coursing from the apex of the heart to the both sides of the ventricle, anterior superior and posterior inferior. So for morphological classification of the VSD, it's classified into different types like perimembranous, which is the most common, and muscular. Other types is outlet, or one of the type of the outlet is doubly committed subarterial, and the inlets VSD. So for perimembranous defect, which is representing almost or approximately 80% of the cases, the boundaries with this defect almost, or the characteristic anatomical feature for this defect, the perimembranous, is it's usually opens into the central part of the base of the ventricular mass, just adjacent to the interventricular component of the membranous septum. And usually this type of perimembranous is covered by the opening septal leaflet of the tricuspid valve, and usually it will be in the area of anterior septal commissure of the tricuspid valve, and it will be just below or near below the commissure between the right and non-coronary leaflet of the aortic valve. Also, in this type of defect, perimembranous, the conduction system is along, as we can see in the photo, is along the posterior inferior rim of this type of defect. For the second morphological classification, which is The muscular type, as we can see in this picture, this is a different type of muscular or trabecular VSD. This type extends through the septum, thus opening in the or within the apical component of the muscular ventricular septum or the muscular part. And those type of VSD exclusively bordered by the muscles or the muscular part of the septum. And usually the conduction system is away from these types of defect. For outlet defects, it can be perimembranous, and usually in this area, it can be perimembranous, it can be muscular, or it can be juxta-arterial defect. It's open in the outlet component of the RV, and it's either behind or near the anterior leaflet of the tricuspid valve, and it is always mostly above the anteroseptal commissure of the tricuspid valve, and usually it lies between the limbs of the septal band. So in outlets perimembranous defect and outlets juxta-arterial defect with a fibrous inferior rim, usually the conduction system along the posterior inferior rim of the defect. In outlet muscular defect and juxta-arterial defect with muscular posterior inferior rim, usually the conduction system away from those type of defect. For the inlet defects, this can be also muscular, can be perimembranous defect with or without AV septal alignment. It's open in the inlet component of the RV and extends behind the septal leaflet of the tricuspid valve. It's below the anteroseptal commissure of the tricuspid valve. And the inlet perimembranous defects, and those type of defect, inlet perimembranous defect, the conduction system will be along the posterior inferior rim of the defect. And in inlet muscular defect, the conduction system is away from the rims of the defect. So here is the some types or some sub-classification for the type of the VSD, which is in perimembranous. You might be in the inlet part of the ventricular septum, or in the outlet with outlet extension or with anterior extension. In muscular VSD, it could be in the outlet or conal part, trabecular, in the inlet, in the anterior, or in the apical part of the septum. Also, other classification is the doubly committed, as we mentioned previously, and the inlet parts as a sub-classification for this morphological classification is the AV canal. In malalignment time, the alignments is related to the alignments of the trabecular to the conal septum. And usually embryological looping of the hearts, usually if the aorta seems displaced relative to the VSD. And there is a different type of this malalignments. If there's anterior malalignments, usually with the trology of fluid, posterior malalignments with interrupted aortic arch or coarctation, rotational malalignments with toothing pink type. Associated lesion with VSD, almost 50% with associated lesion, or almost 50% of the VSD is associated with anomalies. Most common is the BDA in 60% of the cases, coarctation in 5 to 10% of the cases, and aortic stenosis in almost 2 to 3% of the cases, and subvalvular more common than valvular stenosis. So the pathophysiology of the VSD, here as we can see, this is the right side of the heart, left side of the heart. This is the defect in the ventricular septum. Usually it's determined by the size of the defect and its location. So if the defect is smaller than, if the defect is smaller than the aortic annulus, so this is a restrictive VSD. So the shunt direction and the volume, So if the defect is smaller than the aortic annulus, so this is called a restrictive VSD. Then the shunt of this type of VSD, the restrictive VSD, the shunt direction and volume is determined by the difference in systolic pressure of both ventricles. So if this VSD is a restrictive VSD, that means the size of the VSD is smaller than the aortic annulus. So this is a restrictive VSD. The shunt direction, the direction of the flow, and the volume of the blood will be determined by the difference in systolic pressure between the LV and the RV. In case if the defect is larger than the aortic valve, so this defect or those type of defects will be a non-restrictive VSD. And the pressure in both ventricles usually will be equalized. So the direction, the shunt direction and volume of this shunt will be determined by the difference in pulmonary vascular resistance and systemic vascular resistance. So this is the main difference between, or in the pathophysiology of restrictive pattern of the VSD and restrictive pattern, non-restrictive pattern of the VSD. It's back again to the restrictive VSD, which can be further classified or categorized into small or moderate in size. Usually a small VSD has a large resistance for the flow. So this will result in a small left to right shunt, and the pulmonary vasculature is protected. So this small shunt, or the small shunt volume, does not increase the ventricular work or volume. So the left atrium and the LV tend not to dilate. But in case the large pressure gradient across the small VSD, the large pressure gradient across this small VSD is favoring the left to right shunt through the cardiac cycle, which produce the continuous murmur. And this is usually the initial suspicious in the physical examination for a child or for the pediatric patient that has a high suspicious of restrictive VSD. For moderate sized defects, which remains restrictive, but a large enough left to right shunt to cause lift. So in this type of cases will be more volume shunting through this defect. So this will lead or will cause left-sided volume overload, and this will lead to left atrium and LV to dilate. So the pulmonary vasculature in this type will remain protected, but however, in some cases, pulmonary hypertension can exist, which will cause RV pressure and the work to increase. And this will eventually result to RV hypertrophy. So this is regarding to the restrictive VSD, the small restrictive VSD and moderate restrictive VSD. Regarding to the non-restrictive VSD, this will allow the RV and LV to have almost equal pressure with determination of the flow across the defect resulting from the outflow resistance. So the flow of the non-restrictive VSD is depending on the outflow resistance of the LV and the RV. In the LV, this is determined by the systemic vascular resistance or by the LVOT anomalies like subaortic stenosis, aortic stenosis, or coarctation, and etc. In the RV, the flow of the VSD is determined by the pulmonary vascular resistance and or by the RVOT anomalies like pulmonary valve stenosis or in case of tetralogy of Fallot. Usually for the pulmonary vascular resistance, it is high at birth and it decreases gradually. And when the pulmonary vascular resistance is high at birth, this will lead to decrease the left to right shunt. So it's a vice versa relationship between the pulmonary vascular resistance and the left to right shunt. However, the pulmonary vascular resistance naturally decreases as the pulmonary vascular beds matures. So the decline in pulmonary vascular resistance will occur mostly over the first few days. But this process is not completed until 2 to 6 weeks after birth. So in non-restrictive VSD, which is characterized by large left to right shunt, which will cause volume overload of the left side of the heart, that will lead to the dilatation of the left atrium and the LV, and the shunt will also result in, or this shunt will also result in pulmonary hypertension. So, which in time will cause RV hypertrophy and increasing pulmonary vascular resistance. So, as the pulmonary vascular resistance increasing, the left to right shunt will decrease. And this will lead to the end stage of pulmonary vascular disease, which will appear with the child or with the adolescent, and the shunt can even reverse the direction to right to left shunt, like in cases as in Mengele syndrome. So the reversal of the shunt and cyanosis, it's really representing or presenting in the childhood or in the children age group, and it is really present below the age of 5, especially with isolated VSD. And it is usually seen in adolescent and adults. So for the natural history of the VSD, spontaneous closure in majority of the cases, 80% seen at age of 1 month, 60% seen at age of 3 months, and 25% with spontaneous closure is seen at age of 1 year. The VSD that are muscular or juxta tricuspid are most likely to close spontaneously. Adherence of the tricuspid valve leaflets and chordal tissue is an important mechanism for perimembranous VSD, which can also result in LV to RA shunting, Gerbody defects. Aneurysm of the membranous septum functionally reduce the size of the VSD, but this will promote the tricuspid, will promote or will lead to the tricuspid regurgitation, and is a nidus or is considered as a nidus for endocarditis. So the pulmonary vascular resistance will increase with age if the VSD is still and it is non-restrictive. Endocarditis are rare with a VSD, but it's more common in small or moderate VSD. 9% mortality at age of 1 year with a large VSD if left untreated. Late death, especially with Eisenmenger syndrome in adolescent and young adult. Aortic regurgitation also can develop, especially during the first decade of life in 5% of the cases. Clinical presentation is ranging from asymptomatic child with restrictive pattern of the VSD to severely symptomatic with a heart failure symptom, poor feeding, growth failure. If the patient can be tachypneic, pansystolic murmur, and hyperactive heart. Investigation, what we usually did with the routine investigation, we will do chest X-ray. We're looking for the pulmonary vasculature, increase of the pulmonary vascular markings, cardiomegaly with the congestive heart failure, do the ECG, looking for the RV hypertrophy and LV hypertrophy, echo size, but the VSD size categorized, large, moderate, or small. Large VSD, usually the diameter. In large VSD, the diameter will be more than 75% of the aortic annulus, and the flow velocity is less than 1. In moderate VSD, the diameter is usually between 33 to 75% of the aortic annulus, and the flow velocity across the defect is 1 to 4. Small defect, usually the diameter is less than 33% or 1/3 of the aortic annulus, and the flow velocity is more than 4. And cardiac cath, in some cases, that need the cardiac catheterization. For the pulmonary vascular resistance, we can calculate. It is important for determining operability for some such cases. Most accurate if calculated with body surface area. Usually pulmonary vascular resistance, the normal is less than 4 units. Mild pulmonary vascular resistance is 4 to 5, moderate is 5 to 8, and severe more than 8. This is an image from the echo, which showing this is the LV, and this is the LA, the aorta, and this is the RV, and this is the defect in the interventricular septum, and the jet as shown. So the indication for surgery with a large VSD, usually the large VSD in less than 3 months with a congestive heart failure, and QBQS is more than 2 to 1. At age of 6 months, it's elective repair if the pulmonary vascular resistance less than 8 units. In a small VSD, if the QBQS is less than 2 to 1, if the patient develop endocarditis, heart enlargement, or any aortic regurgitation. In subarterial VSD, any size, it's an indicated for surgery. So the principle of surgery, the BDA, if it is present, which is the most common anomaly associated with the VSD, we should ligate prior to cardiopulmonary bypass, try to avoid the conduction bundle, and close the defect with a patch, RA approach whenever possible. So we will talk about the surgical approach. We have a different approach: transatrial approach, right transatrial approach, pulmonary artery approach, transaortic approach, RV and LV approach. For transatrial approach, the majority of the VSD, like perimembranous inlets, and the majority of the muscular defect can be addressed via right atrial approach, which is the most common for the VSD or the most common approach for VSD closure. So initially, the leaflets or the septal leaflet of the tricuspid valve are retracted to will visualize the defect. Then sometimes there is a particular variation in the technique to visualize the defect, either the inlet defect or the perimembranous VSD with some outlet extension. Either we can do with this type of defect like an incision in the septal leaflet and or the anterior leaflet of the tricuspid valve. So this will give an excellent or provide an excellent visualization of the repair. And once the repair or the closure of the defect done or completed, the tricuspid valve should be reconstructed. So the actual closure of the VSD can be done with a patch which secured to the septum, either with interrupted pledgeted stitch, like in this picture, or with a running a stitch, or a combination between both. So the patch can be made of various materials, including autologous pericardium, Dacron patch, or Gore-Tex. For the primary closure without a patch is usually reserved for a small muscular VSD. And one of the most important thing in successful VSD closure, or a key to successful VSD closure, is that the awareness or the surgeon awareness of the conduction system and the aortic valve. So the tricuspid valve annulus, which is the structure where the VSD batch is anchored. So the VSD batch is anchored to the tricuspid valve annulus posteriorly and superiorly, is just anterior and sometimes in fibrous continuity with the aortic valve. So, or therefore, the aortic valve leaflet are at high risk for injury when these superior stitches are being placed. Also, the conduction system, as we mentioned before, is at risk in stitching, especially in the inferior rim of the VSD, with the inferior rim of the perimembranous VSD between the muscle of, or the papillary muscle of the conus and the tricuspid valve annulus. In this area, or in the inferior rim of the perimembranous VSD, running the conduction system. So there is a high risk to injure the conduction system. So in this area, the interrupted suture can be taken far from the inferior rim, or a running stitch, or we can do running stitch can be also placed, and it should be very superficial along this rim. And it is important to remember that the conduction system exists only in a muscular tissue, not in a fibrous tissue. So this is regarding to the transatrial approach. For this other surgical approach, which is less common performed, the first one is for the subarterial VSD, which is the pulmonary outflow through the pulmonary artery, or the pulmonary artery approach. And this approach is usually reserved for the outlet defects. So the pure outlet muscular defects can be closed with a simple primary or a patch technique. And but however, majority of the outlet defects will be about or near to the pulmonary valve annulus. So these defects, and most of them in the outlets or the outlet defects, are closed with a patch. In this particular VSD, this type of defect, the outlet defect, has the highest instance of significance aortic involvement. So the aortic valve leaflet, which is usually the right coronary cusp, can prolapse and or fill the defect. So it is essential to identify the aortic valve and not including it in the repair. So the batch will not only, after we close the VSD, the batch will not only close the defect, but also it serves to support the aortic valve and eliminate the Venturi effect, which can cause or which can lead to the aortic valve prolapse. Also on this approach, some mild form of aortic insufficiency will improve with the repair or after the repair of the defects alone. But this thing is not or is unpredictable. So if the aortic insufficiency is moderate or greater, and or the aortic leaflet clearly has a pathological change, so the aortic valve should be addressed. In other surgical approach, which is like in cases of Swiss cheese septum or multiple muscular VSD, and those type of defect may need LV incision. The RV approach is rarely used nowadays. And there is another surgical approach, which is transaortic approach, which is usually applied in addressing a VSD that is associated with another left-sided lesion, such as patient has aortic insufficiency, valvular or subvalvular stenosis. And usually those type of defect to be closed from the RA approach to avoid left bundle branch block. Another less invasive approach with a high-risky patient, or if the surgery contraindicated, is the transvenous closure of the VSD with a device, for example, umbrella device, and usually it is applicable to apical defect. If the VSD associated with aortic regurgitation, the different technique might be used, like Trossler technique or Yacob repair. We will see in the next slide. Older children with persistent small, for the older child with persistent small VSD, there is some factors favoring of no operation, like if the defect that's the defect, or the belief that the defect may still close spontaneously, and only some adverse effect can happen for that child, like endocarditis, which is mainly or majority of the children can be treated or managed medically. And that's the operation carries a small but real risk. Factors that favoring of the surgery, that there is still the possibility of the endocarditis and psychological impact on the adolescent, that the ventricular dysfunction can or might be still developed even with a small type of VSD. And that's high probability of cure with the surgery. So if the patient has a VSD and aortic regurgitation, or VSD and AR syndrome, it's related to congenital sinus of Valsalva aneurysm and tetralogy of Fallot with AR, and most often or mostly caused by prolapse of the right coronary cusp. This prolapse and protrusion through the VSD, usually during the diastole, and effectively bulge the VSD and limiting the shunt, even if the defect is large. Usually it's adjacent, the adjacent sinus of Valsalva is enlarged, and the aortic regurg does not usually appear until age of 2 to 5 years. It gradually increases and becomes severe, probably or approximately within age of 10 years. So when a child with a VSD first develop an aortic regurgitation murmur, we should address that. VSD should be promptly repaired, and doubly committed subarterial VSD and moderate large perimembranous VSD should be closed by age 5 to prevent cusp prolapse. An operation should certainly be done before age of 10, because the aortic regurg will become more severe with age, and because the valve reconstruction is usually possible in the first decade of life. Operative technique for VSD and AR syndrome, either Trosler repair, Yacob repair, or Carpenter repair. In Trosler repair, so we can do the cusp plication at free edge of the leaflet at one of the commissure of that prolapse cusp, and a standard VSD closure. So in this image, we can see the Trosler repair. So we can do the cusp plication for the at one of the commissure, and we will do the standard VSD closure. In Yacob repair, we can do the matrix suture through the ventricular septal crest and aortic annulus with the simultaneous elevation of the cusp and annulus and closure of the VSD. So this is the image. As we can see, this is the aortic cusp. This is the crest of the ventricular septum, and this is the VSD, the defect. So with matrix suture, we can take a stitch for the aortic cusp with the crest of the ventricular septum and tie together. This will lead to closure of the VSD. This will lead to closure of the VSD and ensure the aortic valve. Carpenter repair we should do triangular excision and reconstruction of the valve, and also the LV aortic junction angioplasty, and we will do the standard VSD batch. So in Trosler and Carpenter, standard VSD batch plus aortic repair. In Yacob repair will be simultaneous elevation of the cusp or simultaneous aortic repair plus closure of the VSD. Straddling of the aortic valve, it occurs when part of the caudal apparatus crosses the VSD and attaches to the opposite ventricle. And this is usually associated with some degree of valve override, usually competent and identified with echo. And those defects requires modification of the VSD batch and or valve realignment. So the complication from surgical intervention of the VSD closure, one is a tricuspid valve insufficiency from caudal shortening or leaflet entrapment by the VSD batch, or leaflet distortion if incised for exposure. The second might be possible aortic valve insufficiency if the suture in the superior aspect of the patch catch or damage the aortic valve. The third thing, congenital, complete heart block if the bundle of His is damaged or transected by the suture. Sometimes temporary block can occur secondary to edema in the area or trauma caused by careless suctioning or manipulation around the AV node area with the instrument. Also, one of the important complications that might result is residual VSD. So this was the most important complication with VSD, surgical closure of the VSD. So we end with our topic, VSD. Thank you for listening. Any question?
يعطيك العافية يا دكتور.
الله يعافيك.
Thank you, Abdullah. Nice presentation.
السلام عليكم يعطيك العافية دكتور عبد الله. Nice presentation.
وعليكم السلام. الله يعافيك.
Dr. Farid, from your experience, if post-op you did echo and you found residual VSD and patient difficult to wean from oxygen, when the best time to take this patient to operation?
I'm sorry, I didn't get that. So you said the patient is already post-op?
Post-op, assume day 5, and difficult to wean him from oxygen, and you did the post-op echo and you found residual VSD.
Okay, so the weaning of oxygen is related to, I presume, hypoxemia. And the question here always comes, what kind of shunt did this patient have to have hypoxemia? Or is it related to pulmonary edema and the lung is congested and the patient is having problems with oxygenation? There are two different issues here. The preoperative decision to operate on such patient if they have pulmonary hypertension or high resistance pulmonary circulation. And now when you do the echo post-op and you find a right to left shunt resulting in this hypoxemia, of course, the treatment here is totally different. And maybe the decision to take the patient for surgery was at question. The more likely scenario is that this patient has a large VSD to start with, and he's having pulmonary edema, and you couldn't wean him off the ventilator preoperative, and you had to operate on him earlier. Now you operate on this patient and you have a residual VSD that's still significant, and the patient's still on the ventilator. If the calculated shunt, either by echo or even repeated cath for confirmation, shows significant shunt, the patient should go back to surgery, and he can go back right away. The best time, of course, to operate on the patient is during this period. The worst time to operate on patients' redos is maybe somewhere between 6 weeks or around 6 weeks. So let's say 4 months. So sorry, 4 weeks to 8 weeks is a dense adhesion, a lot of adhesions, a lot of problems with that. So if the patient can tolerate and he's having only mild congestion and he's on starting on medical treatment, diuretics, etc., and the patient can tolerate being off the ventilator as well as being discharged home, then that patient you can delay the surgery until later. There may be a good chance that the patient may have his own residual VSD closed spontaneously, but it's, I would say, it's a fat chance. It's more likely that the patient will need to have to go back for surgery with these symptoms. Does
Thank
that
you.
answer the question,
Yes.
Hussein?
Yes. Thank you.
Okay.
Dr. Farid,
Go ahead.
is it possible that we might miss a residual VSD during testing it يعني intra-op or by echo?
Of course, that's a very common scenario, but with experience, we would expect you to develop that sense of not leaving behind significant VSD. Yes, there is also a small chance that you may leave somewhere, but passive testing is not perfect. Let's put it this way: it will only show very large residual or different VSD that you have missed, or maybe the patch was sutured to a bundle that's not part of the VSD. It's not the VSD rim. So all these have to be taken into consideration. But and some people, especially early on their career experience, they insist of doing echo just to make sure that they have got everything right. The potential to leave a small VSD is very common. It's not. The repair itself is not usually perfect. There are suture lines anyway, and you may have some small leak here and there around the sutures, which is acceptable. And usually it does not harm the patient and it closes on its own.
Okay, thank you.
Okay. I have a question, not question, but comments about the presentation. Dr. Carpentier, the name is French. It's not Carpenter. It carries the same meaning. Very famous surgeon, and he's well known for valve repairs, in particular for the mitral valve. Dr. Khoury is the one that has advanced the aortic valve repairs. He's in Belgium. But the different techniques that you have mentioned related to subarterial VSD closure, unless they are really very small, I think it's better to use a patch rather than repairing or touching the valve leaflet. If you have, it's a controversial issue. It's not that clear. The answer is not that clear. So if you have a subarterial small with restrictive, very small VSD, the chances of developing endocarditis is rare. We have many patients in our practice that our colleague cardiologists have elected to observe them for a long time, and they usually don't have any problems. So unless the patient is having a new development into the aortic valve function, like during the period of observation, the patient develops some AR, that usually does not prompt us in our practice to go for surgery, unless the patient developed a new AR, for example, or the patient is having significant AR that had been persistent for some years. Usually, we would like to intervene earlier if that happens. I worry personally about putting sutures through the sinus and plication form like what has been described, but I feel that if that results in damage, you usually end up with significant damage to the aortic valve with no, basically with no return. The patient may require replacement. So in those cases, if the sinus itself is aneurysmal, it should be repaired properly with a patch. And if the VSD is closed by quite a bit of aortic tissue or sinus tissue or leaflet tissue, I tend to accept that but putting the patch, I remember talking to Hussein about this in one of the patients, that I usually put the patch way above that area to almost like to support the area that was already closed by the aortic leaflet. So it's more like supportive structure. You mentioned something about the material used for patch, and you mentioned autologous pericardium. We avoid using autologous, even treated our autologous pericardium, because of the chances that they may develop aneurysm. The practice goes either for synthetic materials like Gore-Tex or Dacron patches, but in our practice, we have leaned toward pericardial, bovine pericardial patches, which have proven for the last, 30 years or so, 30, 40 years now in King Faisal to be a very good alternative. Okay, well, those are my comments. By the way, when you are expected to talk about VSD and your board, is congenital in general is not a major part of your board exam. I think it's much amalgam to somewhere around 10% maybe of the exam. But in the VSD topic, just like you have mentioned, the potential of complications, the managing of avoiding conduction problems and avoiding tricuspid valve injuries or aortic valve injury, and the technical aspect of the procedure. More importantly, they may ask you about management and decision making preoperatively and postoperatively, especially ICU care, arrhythmias, and things like this, which may happen. Thank you.
Thank you, Dr. Farid. So we'll have a 10 minutes break and we'll start with the second lecture.
Right.
Yes.
I'm not sure if you're expecting with the rest of the sessions anybody to help with that, or
no, I don't think so. Dr. Atizaz is, I think, busy in an emergency surgery. So
okay. Therefore, I'll be around if you want me to comment on anything. I'll stick around with you guys.
thank you, Dr. Dr. Hammam.
السلام عليكم.
عليكم السلام. You can start.
Today we're going to talk about total anomalous pulmonary vein connection. I'm Dr. Hammam from Ministry of Defense, Medina Cardiac Center. We will start by definition. Total anomaly of pulmonary vein is an anomaly in which the pulmonary vein have no connection with the left atrium, rather than the pulmonary vein connected directly to one of the systematic vein. A pulmonary patent foramen or valor ASD is essential in those patients for survival after birth, so it's an obligatory shunt. When pulmonary vein drain into the right atrium because of complete absence of interatrial septum, then it is known as a total anomalous pulmonary vein drainage. In the history, Wilson, first description was by Wilson in 1798, a description of a very unusual formation of heart, total anomalous pulmonary vein connection. Muller done first successful open repair in 1951. Incidence, the total anomaly occur in approximate 6 to 4 per 100,000 live per year. This anomaly accounts for 3 to 1% of cases of congenital heart disease. 6 ratio with supradiaphragmatic total anomaly is about equal. Male is 4 to 1 is seen in infradiaphragmatic type of total anomaly. Associated cardiac anomaly is TGA, tetralogy of Fallot, single ventricle, truncus arteriosus, tricuspid atresia, hypoplastic left heart syndrome, and coarctation. Anomaly connection to the right atrium or connection to the right common cardinal system like an SVC or azygos vein, connection to left cardinal system, left innominate vein or coronary sinuses, connection to umbilical vitelline system, such as portal vein, ductus venosus, or hepatic vein. Classification of total anomaly. The most popular one is Darling classification, 1957. Type 1 is the supracardiac connection. 45% is the most common venous connection to the SVC, the most common type. Second type is cardiac total anomaly, account for 25% of cases, drain into coronary sinuses or directly into the right atrium. Type 3 infracardiac total anomaly is account for 20% of cases, drain into hepatic vein, ductus venosus, portal vein, or IVC. The common pulmonary vein penetrate diaphragm through esophageal hiatus in this type of infracardiac anomaly. Last type is mixed type, account for 10% of cases. Another classification is Neal classification, embryological basis, not commonly used this day. Divide into 2 groups. Group 1 have a connection to the right atrium or right common cardinal system. Group 2 connection to the left cardinal system, left innominate vein or left SVC. Another classification is Smith classification into 2 groups, supradiaphragmatic without pulmonary venous obstruction, Second is infradiaphragmatic with pulmonary venous obstruction. Site of obstruction at atrial septum or in the anomalous vein. The first one, the obstruction intraatrial septum, the lengthy in total anomaly is related to the size of the AST. Those patients with large defects survive longer than the patient with restricted intra-arterial opening. In second type, obstructed anomalies in venous channel, intrinsic narrowing in frequent in wall of anomalous vein, and extrinsic venous compression may be also occur. Infracardiac type is usually obstructed, while the supracardiac and cardiac type are often non-obstructed. Also here, site of obstruction, you can see the extrinsic pressure may result in narrowing in the venous structure. For example, like in vertical vein to innominate vein, pass between the dilated left main pulmonary artery, anterior and to lift to the left bronchus posteriorly. Anomalous venous connection to the superior vena cava may be obstructed by right pulmonary and trachea also. When anomalous connection is to the portal vein, resulting in increased resistance to the pulmonary vein return. Physiology, all venous blood return to right atrium, so the survival of child is dependent on the presence of right to the left shunt, ASD or patent foramen ovale. The major hemodynamic depend on the size of communication and presence of absence or in the presence of absence of obstruction, a relative resistance to systemic and vascular resistance. In patients with restrictive intra-arterial communication, the amount of blood to the left atrium is limited and systematic output is reduced. After birth, pulmonary vascular resistance decreased and systemic demand increase. So the pulmonary circulation increase and systemic venous return to the right atrium increase, which will lead to increase in the right atrium pressure, which will result in elevated pressure and congested both venous circulation. In the presence of wide communication, the distribution of mixed venous blood depends on the relative compliance of ventricle and atrium and relative resistance to pulmonary and systemic circulation. Mainly, it will be depend on the venous pressure. Right atrium will receive an entire venous return from systemic as well as from the pulmonary circuit. So after birth, the pulmonary vascular resistance will be decreased and RV will compliance to increase more blood to comes to the RV. Pulmonary blood flow is more than 5 times than systemic flow, which lead to the RV failure in neonate and infant. Pressure in right atrium and left atrium are equal, and oxygenation saturations will be equal in all cardiac chambers from 85 to 90%. Later on, the pulmonary vascular disease develop, which lead to the decrease in pulmonary flow and decreased systematic desaturation. So cyanosis will become prominent. The hemodynamic of obstructed type of total anomaly is similar to mitral stenosis. When obstruction is there, the pulmonary venous pressure increase, which lead to increase in hydrostatic pressure and interstitial edema. Infant become very sick and die due to pulmonary edema. Those who survive will develop pulmonary hypertension. Total anomaly without pulmonary venous obstruction patients are usually asymptomatic at birth. The kidney and feeding difficulty are initial symptom, usually within first few weeks of life. Then infant have a recurrent respiratory tract infection and failure to thrive. Mild cyanosis is present because of adequate mixing of blood. Gradually, they will develop a right heart failure and pulmonary arterial hypertension. So clinically feature, those who will survive, their first year almost always they have a supradiaphragmatic connection. low pulmonary vascular resistance, and non-restrictive atrial septal defect. A newborn with infradiaphragmatic connection and asplenia, they may have a major esophageal varices. In examination with total anomaly without pulmonary venous obstruction, there is a mild cyanosis with feature of congestive heart failure, prominent precardium with left lower parasternal heave, S1 loud, S2 with wide split and fixed loud. Total anomaly with pulmonary venous obstruction, clinically, a clinical condition is grave with minimal cardiac finding. There is an apex impulse of RV type. S1 usually is normal, S2 closely split and with B2 loud. Short systolic murmur due to pulmonary artery dilatation is prominent there, and liver is enlarged and tender. In ECG, there is a tall peak to B wave in lead 2, characteristic of right atrial enlargement. RVH is usually present with high voltage and right pericardial lead. There is occasionally an incomplete right bundle branch block. This is an X-ray of supracardiac total anomaly, figure of 8 or snowman. The non-obstructive supracardiac total anomaly to left innominate vein in this picture. This diagnostic sign is usually not present in first few months of life. This picture with obstructive total anomaly X-ray, there is a diffuse reticular pattern. Cardiac size is normal with curly B line present here in this picture. This pattern also seen in other causes of pulmonary venous obstruction. Diagnosis mainly by echo. 2D echo with color Doppler is definitive non-invasive method for diagnosis of total anomaly. The reported sensitivity and specificity of echocardiography was in 97 and 99, even before availability of color Doppler. Sensitivity of 100% and specificity of 85 is claimed for detection of obstructive by 2D echo with color Doppler. Goals of echocardiography: to detect size of pulmonary vein, connection of all 4 major pulmonary vein and additional pulmonary vein, size of pulmonary vein and its relation with left atrium, and course of pulmonary vein channel to whether if there is an obstruction to the flow or not, and if there is any additional cardiac anomaly. Feature common to be found in echocardiography for total anomaly: sign of right ventricular volume overload, and maybe you will find an inability to image, maybe you cannot able to image the pulmonary vein entering the left atrium. This is a limitation of echocardiography. Size of individual pulmonary vein at the time of diagnosis is a strong independent predictor of the survival. Smaller pulmonary vein were associated with poor diagnosis. Another modality for diagnosis of total anomaly is CT. CT is excellent despite of vascular structure peripheral to the heart, which will make it difficult to detect it in CT. But with the new scanner rapid imaging, it is possible without need for sedation even though. This disadvantage of CT is that it's required in ionizing radiation and IV iodine contrast material. Third modality for diagnosis is MRI. MRI is superior to the CT imaging. Imaging technique for evaluation of pulmonary vein structure after echocardiography is routine in some hospitals to do an MRI after suspected echocardiography finding of total anomaly. But lack of ionization radiation and need for single IV bolus contrast the advantage of MRI over the CT. But it needs a long time and susceptibility for material artifact are disadvantage for an MRI. Cardiac catheterization is diagnosis is rarely performed to the total anomaly. Cardiac cath is reserved for precise examination of pulmonary vein and other obstruction. The pathogenomic finding is oxygenated saturation in all chamber is greater than fizzle, and nearly 80 to 90%. Cardiac catheterization in obstructed type RV and pulmonary artery pressure are increased and maybe are equal in more than systemic pressure. So the patient with systemic arterial saturation more than 70 and pulmonary artery pressure at or above systemic level are likely to have a significant pulmonary venous obstruction. Pulmonary artery pressure more than 2, excess of left atrium is more reliable in predicting the restrictive inter-arterial communication as compared to the presence of equal pressure in 2 atria in predicting non-obstructive inter-arterial communication. Compliance and filling pressure of both ventricle are comparable. Cardiac catheterization in infracardiac type anomaly, connection of pulmonary vein via descending vertical vein to portal vein is characteristic, and it is termed as an tree in winter in this picture. In neonate umbilical vein catheterization, always direct injection of contrast in anomalous connection in the infradiaphragmatic type of total anomaly. Catheterization is also helpful in defining the pulmonary vein stenosis in post-total anomaly repair patient. Selective pulmonary arteriography is also one modality of diagnosis of total anomaly pulmonary vein. If pulmonary vein cannot be entered directly, then the selective right pulmonary artery angiography is done. Pulmonary arteriography show the anomalies of venous connection in this picture. History, natural history for patient with total anomaly. Among the patients with total anomaly of all type, more than 50% they will die at 3 months, and almost 80% will die by the age of 1 year. When obstruction exists in anomalies venous channel, the prognosis is bad. Death usually occur within first few weeks of the life. Hazareg and his colleague analyzed in 183 autobiopsy cases of surgical untreated total anomaly. Median survival was in 2 months, with shortest is 1 day, longest with 49 years, and 90% of deaths were within first year life. Pulmonary obstruction significantly reduced survival from 2.5 months in non-obstructive group to 3 weeks in obstructive group, with value less than 0.0001. Differential diagnosis in non-obstructive total anomaly, we have to differentiate between total anomaly and TGA because they will present with the same presentation almost. And in obstructive type of total anomaly, the lesion will be like an mitral stenosis and pulmonary venous congestion. Complication of total anomaly, congestive cardiac failure, growth and developmental delay, frequent respiratory infection, pulmonary vascular disease, pulmonary edema in obstructive type. Management, corrective surgery is the definitive treatment for total pulmonary artery. An infant present with obstructive total anomaly of pulmonary artery represents surgical emergency. So they need and require an intensive resuscitation before going to definitive surgery. A non-obstructed total anomaly patients are relatively stable and can be taken for elective correction surgery within few days of diagnosis. In emergency medical management, immediate and endotracheal intubation and hyperventilation with 100 oxygen and BaCO2 of more than 30 and correction of pH. Induced respiratory alkalosis will decrease the pulmonary vascular resistance and improve in oxygenation. Metabolic acidosis should be treated with sodium bicarbonate infusion. Function of failing heart augmented with inotrope and diuretic. Isoprenolol has the same effect of inotropic support in obstructive total anomaly because it has a pulmonary vasodilatation property. prostaglandin infusion given to maintain patency of ductus venosus to decompress the pulmonary vein in obstructed total anomaly. ECMO may be used in infants with severe pulmonary hypertension and refractory cardiac failure. Ballooning or plate atrial septotomy may be used as a palliative procedure. It's not appreciated because it will be delayed the definitive procedure, and is if no value in obstructive total anomaly. The goal of surgery is to create an unobstructed pathway of blood from pulmonary vein into left atrium. Usually there is an three surgical approach: posterior approach, right atrial approach, and superior approach. We will start by posterior approach. In posterior approach, the pulmonary vein is seen in the posterior pericardium by retracting the heart anteriorly and to the right. Because of lack of pulmonary vein attachment to the left atrium, the heart is more mobilized and pulmonary vein can be easily exposed. A longitudinal incision is made in the venous to match the corresponding incision in the posterior left atrium. It is challenging to orient the left atrial and pulmonary vein to incision while spontaneously you retracted the heart. Retraction may be placed tension on the suture line of anastomosis. Limitation to the rightward extension of anastomosis, and more so when the venous is oriented rightward to the heart. Another approach is right atrial approach. Arteriotomy incision extend across the right atrium and then across the atrial septum. It allows an incision in the posterior wall of the left atrium, precisely over the pulmonary vein. In the patient with left atria and rightward pulmonary venous, this approach allows an patch augmentation in the left atrium, where reconstructed the atrial septum and right atrial incision. Last approach is the superior approach. In this approach is specially used in patients from the pulmonary venous drain to the SVC and RA junction. Aorta and SVC are retracted laterally, exposing the left atrium and pulmonary venous. Repair of cardiac type of total anomaly. Let's see here. There is an incision between coronary sinuses and patent foramen oval with unroofing the coronary sinuses that will create a pathway between the pulmonary venous return to the left atrium. In infracardiac total anomaly, the pulmonary vein is more vertical oriented, so the incision in the left atrium is vertical or Y-shaped to maximize the size of anastomosis. Vertical vein is left intact to provide pressure relief, pop-off. If left atrial pressure is high in early postoperative period because of small left atrial size and poor ventricular compliance. Surgical outcome. Surgical mortality has decreased from 50% in 1960 to more than 5% recently. Risk factors are young at operation, pulmonary obstructed vein, infracardiac vein, emergency operation, refractory pulmonary hypertension, and cardiac failure. Complication of surgery, and then early complication is pulmonary edema, pulmonary hypertension crisis, phrenic nerve injury, rhythm disorder. Latent complication of surgery is pulmonary venous obstruction, anastomotic stricture, and pulmonary venous stenosis. Pulmonary edema, non-compliant left heart, and increased left atrial pressure lead to pulmonary arterial vasoconstriction. Management in this case is diuretic. In pulmonary hypertensive crisis, hyperventilation with 100% oxygenation and inhaled nitric oxide is treatment of choice with infusion of prostacyclin. Rhythm disorder, junctional rhythm, and various types of heart block are common in total anomaly. In infracardiac total anomaly, left bundle branch block is common. Pulmonary venous obstruction, this is the most significant cause of late morbidity and mortality after surgery correction. It develops in 5 to 15% of patients with first post-operative year, where total anomaly is corrected using standard technique. And pulmonary venous obstruction, anastomotic fibrotic stricture, and intimal proliferation and diffuse fibrosis are pathogenomic mechanism. Various surgical technique, revision of common pulmonary vein to left atrium anastomosis, patch angioplasty of stenotic pulmonary vein, suture of individual pulmonary vein directly to the left atrium, and sutureless repair in new atrium creation. Sutureless repair and new creation of new atrium is definitive treatment of complication of within first year of correction of total anomaly of pulmonary valve. Conclusion: total anomaly is rare congenital heart anomaly, but present as a surgical emergency in neonatal period. Echocardiography is the diagnostic modality of choice. Cardiac catheterization is rarely needed for diagnosis. Surgical correction is definitive treatment. Improved in surgical technique and hospital care have led to significantly better outcome of total anomaly surgery. Sutureless repair is safe and effective method to deal with post-operative pulmonary venous obstruction. That's it. Thank you.
Okay, thank you, Hammam. Any question for Hammam? Dr. Farid, do you have any comment?
So this is a very nice review. By the way, the Dr. Fellow, it's not Fallot, Fellow is also a very famous, I would say, physician related to who have described this pathology of tetralogy. But the association of different diseases is usually not that great. It's usually a solitary lesion most of the time. And just like you said, the obstructive type is an emergency. It's a true emergency. Nothing will help those patients. And the medical treatment you mentioned, which will lower the pulmonary resistance or trying to clear the lung, is usually not effective in those patients. The best thing for those patients is to go to surgery immediately and place the patient on bypass as soon as possible. Then you start resuscitating the patient, correcting the metabolic and the electrolyte issues. After a few minutes, let's say after 15 minutes or so of resuscitation, by that time you can complete your dissection. Different people have different approach, and most of these approaches are successful. I personally prefer the transatrial approach, so I go through the right atrium. The obstructive type, just like I said, is a true emergency, and you really should not wait any long. You may face some patients who are not even, by the time you try to take them to surgery, within an hour or so from the diagnosis of birth, after birth, you may have to place some of those patients on ECMO. Those true emergencies are rare. We see about maybe one every year or every 2 years. So it's not that common. The other thing I wanted to mention is that the post-operative care may be difficult because of the severe pulmonary edema that those patients are in, if it was done as an emergency. And that's what brings the mortality rate of those patients high. And those are the same patients who would require some sort of support if they cannot wean off bypass, for example, ECMO, or being on the ventilator for some time. Again, thank you very much. Nice presentation.
Dr. Farid, in case if there is no obstruction, what's the time window you will take the patient to OR?
With no obstruction, it's basically an elective procedure. So you take care of all your preoperative assessment and decision making diagnostically. In our team, we rely mostly on the echo, but occasionally we would have to resort to other modalities of imaging. And if that happens, then that may delay the surgery for a few days.
Few days. So you will not discharge the patient and electively.
Well, most of those patients actually, if they are not obstructed, they're already like a few years old, 3, 4, 5 years old. Some of them even older, like teenagers, and they would come to the clinic. So it's not like they will be admitted. If they are admitted for any reason, usually it will be the heart failure symptoms that may need to be taken care of. But the majority of those patients are having mild symptoms, so they will come to the outpatient, and it's not like that an urgent process should be taken. No, usually elective procedures. So it depends on your load of cases, I guess. In our case, most of those patients electively, once they are referred to us, they are on the table, let's say within 2 months from that referral. There's something that I think is important for you know, if the patients have pulmonary venous obstruction at the level of the action of vein with the atria. Very difficult cases to deal with.
Your voice is not clear, Dr. Farid.
There is a
We
very
cannot hear
poor
you.
prognosis. I've seen many.
Cannot hear you well, Dr. Farid. We lost your voice.
Hello?
Yeah,
Can you hear
Dr.
me now?
Yeah, yeah.
Okay.
We didn't hear the
I just switched.
information well. Yeah.
Okay, I just switched the net connection. Anyway, so go back to the issue of pulmonary venous obstruction. Pulmonary venous obstruction in total anomalous is very significant prognostic issue. If it's somewhere distal, for example, the infradiaphragmatic, usually somewhere in the livers. Therefore, using on those cases some prostaglandin may help because it opens another channel for the drainage, the ductus venosus. So, but if the venous obstruction is at the junction of the veins to the confluence, that can be very ominous and it carries a very poor prognosis, even with many attempts. And by the way, you mentioned that in the presentation, you mentioned that sutureless is very effective and things like this. No, it's not. It's an attempt. It's avoid dealing directly with the veins, and it may be carrying the best results, but even the best results is not that great because the prognosis for those venous obstructions is very bad. Many attempts have been done with stents and with surgical techniques, but it really it just reflects the poor prognosis for those. When I do the suture line for the transatrial repair, I try to avoid being close to the pulmonary veins. So I carry the incision, for example, in the supracardiac, superiorly toward the appendage, and use the appendage as part of the repair to enlarge the size of the of the left atrium. In the inferior infrahepatic type, I would go with the incision down toward the diaphragm as much as possible, and then into the confluence and into the distal vein, which is usually the right toward the right superior pulmonary vein, but not into the vein. And of course, I use the PDS. I'm not sure if it makes any difference, but I believe it may help future disintegration of those suture material, which will lead to better growth of the atrium. Again, no science in that, it's just a feeling. Okay, thank you.
Okay, thank you very much, Dr. Farid, and thank you, Ammam, again. So another 10 minutes and start with the journal club. Muhammad.
Yes.
تفضل. Can start.
Okay. Everybody, today, inshallah, we're going to speak about the trial of a left atrial appendage occlusion during cardiac surgery to prevent the stroke. As an introduction, atrial fibrillation is considered responsible for around 1/4 of ischemic stroke, and majority of it are of cardioembolic source originating mainly from the left atrial appendage. Oral anticoagulation proven to reduce the thrombus formation in the left atrial appendage, and has proven the efficacy and safety in the prevention of stroke related to atrial fibrillation in those patients. Nevertheless, oral anticoagulation has some limitation, most common of which are non-adherence, as well as drug discontinuation, underdosing, and especially for vitamin K antagonists, the poor control of INR level. So in this study, they hypothesized that concomitant occlusion of the left atrial appendage among patients with a history of atrial fibrillation would provide additional protection against ischemic stroke, in addition to the protection provided by the anticoagulation therapy. So the aim of the study was to evaluate the efficacy and safety of concomitant left atrial appendage occlusion in preventing ischemic stroke or systemic embolism in patients with history of atrial fibrillation and undergoing cardiac surgery for other indications, and in whom continued usual care, for sure, including anticoagulation, is involved in the management. With regard to the methodology, initially with the design and oversight, it is considered an international multicentric randomized trial that was funded by peer-reviewed funding sources. And the funder had no role in the design, conduct of the trial, collection of the data, analysis or interpretation of the data, or even the preparation of the manuscript. Each site involved in the trial has to have an ethical approval from their own committee for the trial. And the Population Health Research Institute was the sponsor, served as the coordinating center, and was responsible for the maintenance of the database, validation, and analysis of the data, in addition to trial coordination. With regard to inclusion and exclusion criteria of the participant, the inclusion criteria were patients whom having a history of atrial fibrillation and with the age of 18 years of old and older, who are scheduled to undergo cardiac surgery with a cardiopulmonary bypass, and whom they have a score of at least 2 on the CHAS-2 VASC scale. Exclusion criteria include patients undergoing off-pump surgery, mechanical valve implantation, heart transplant, surgery for complex congenital heart disease, isolated implantation of LVAD, previous surgery involving opening the pericardium, as well as the previous implantation of left atrial appendage closure devices. The procedure, patients were assigned in 1-to-1 ratio randomly using a web-based randomization system, either to go for occlusion or not. And this performed according to a computer-generated randomization, then was stratified according to the trial site. And the participant, the trial personnel, the clinician caring for the participant, as well as the data analyzers, all were unaware of the trial group assignment, apart from the surgeon. And the surgeon only knew about the assignment just before the surgery through a confidential email. And the surgeon has to reply within 24 hours after randomization with regard the performance of the assigned procedure or not, the method used for surgical occlusion, and whether the occlusion was successful or not. Later on, the surgeon and the intraoperative team were not involved in the ongoing management of the antithrombotic therapy or data collection or analysis. The techniques were those were permitted to do during the surgical occlusion included either amputation and closure, which was the preferred procedure. Other procedures include stapler closure, double layer and linear closure from within the atrium. That was specifically in patients undergoing minithoracotomy, as well as closure with an approved surgical occlusion device. Neither the percutaneous closure nor the per-stringing closure were permitted, and intraoperative TEE was used to confirm successful closure. This from the supplemental appendix of the same trial showing the different technique for closure of the epicardial occlusion of the appendage. The preferred one was the amputation of the left atrial appendage as suture closure of the atrial appendage, either with the stapler or the epicardial device closure. Then the participants were followed up either by phone or in person by a local trial personnel, initially at 30 days, and then every 6 months till the end date, which was set by the trial committee. And it was the 28th of January, 2021. And participants were expected to receive, in addition to either surgical procedure or not, a guideline-directed stroke prevention and other usual care, including anticoagulation. And every 6 months, participants were questioned with the use of a validated stroke questionnaire to look if any symptoms indicating a possible stroke had occurred. This is the validated questionnaire that was used in this study. And these are some important definition of the primary outcomes that we're going to speak about them, but just to know, for the stroke, it's defined as the diagnosis of stroke require new focal neurological symptoms with a rapid onset lasting at least 24 hours. And all strokes are classified as the definitive ischemic, definitive hemorrhagic, or type uncertain. Transient ischemic attack with positive neuroimaging are upgraded to a stroke during the blinded outcome adjudication. The TIA was defined as an episode of a new focal neurological deficit with rapid onset of signs, with rapid onset with signs or symptoms lasting less than 24 hours. And systemic arterial embolism is judged to occur where there is a clinical history consistent with an acute loss of blood flow to a peripheral artery, which is supported by objective evidence of embolism. And this also was provided in supplemental document. The outcomes that was set for the study, primary outcome was the first occurrence of ischemic or non-cerebral systemic embolism during the follow-up period. And with regard to ischemic stroke, they included a transient ischemic attack with a positive neuroimaging, as we mentioned earlier. Stroke of undetermined cause were included as ischemic stroke in the primary analysis. Secondary outcomes included any stroke or non-cerebral systemic embolism, ischemic stroke, non-cerebral systemic embolism, death of any cause, 30-day mortality, volume of chest tube drainage within the first 24-hour post-op, re-exaspation for bleeding within 48 hours post-op, hospitalization of heart failure. And with regard to this, they included either prolonged hospitalization due to heart failure or new hospitalization due to heart failure, myocardial infarction, as well as major bleeding. With regard to analysis and statistics, the primary hypothesis was that the risk of stroke or systemic embolism would be lower with surgical occlusion of the left atrial appendage added to the usual care. And a sample size of around 4,700 was estimated to provide the study with a power of 80% power in order to detect a 25% lower relative risk for primary outcome event in the occlusion group than the no occlusion group. And the primary analysis included all participants who underwent cardiac surgery. A time to event analysis was used to test for the primary hypothesis. We're using a Kaplan-Meier survival curves and log rank testing. And with regard to the effective treatment, the hazard ratio was estimated with a 95% confidence interval using a Cox proportional hazard model. An independent data and safety monitoring board reviewed the unblinded data and performed 2 pre-specified interim analyses of efficacy when 50% and 75% of the expected primary outcome event had occurred. And additional Cox models were used to evaluate the interaction between trial groups, assignment, and subgroup of interest. The result of the study, so a total of 4,811 participants were included in the period from July to 2012 through October 2018 from 105 centers in 27 countries, and were randomly assigned to either to go in 2 arms, in which 2,400 participants were in the occlusion group, and the 2,411 participants were in the no occlusion group. And January 28, after the second formal interim analysis, the Data and Safety Board recommended that trial should be stopped and the result to be reported. And the final follow-up was in the period between end of January to early March of 2021. Follow-up in this study, at almost 98% of the participants completed their follow-up, with a mean duration of follow-up was 3.8 years. Around 50 participants had withdrawn their consent, and another 49 participants lost their follow-up. And this is the scheme showing the flow chart of patients. So a total of 4,811 patients were included initially. As we mentioned, 2,400 in the occlusion group, and out of them, 21 excluded as they don't have surgery data. Out of those 21, 16 patients, the surgery was canceled indefinitely. 1 patient died prior to surgery, and 4 patients withdrew their consent prior to surgery. So a total of 2,379 were included in the analysis. In the no occlusion group, around 20 patients were excluded, as 13 patients, their surgery was canceled indefinitely. 2 patients died prior to surgery, and 5 patients withdrew their consent. In the occlusion group, out of the 2,379, only 2,131 patients received the left atrial appendage occlusion, as 240 of the participants, the surgeon did not comply for the assigned procedure for reason or another, and 8 patients either missing or invalid surgeon response regarding the compliance to the allocated surgical procedure. And within the no occlusion group, actually 118 patients received the left atrial appendage occlusion. So with regard to the characteristic of the participant, there is almost a balanced baseline characteristic between 2 arms, with the mean age in both groups of around 71 years, and 67.5% of the participants were men in each arm of the groups. And mean CHA2DS2-VASc score was 4.2. Almost more than half of the participants were originally on anticoagulation prior to surgery. And out of the participants at the hospital discharge, 83% and 81% were discharged on anticoagulation in the occlusion group and no occlusion group, respectively. With that number decreased to 79 and 75% at 3 years. This table showing the basic characteristics with the surgical procedure was indicated for those patients. We can notice that almost both arms are similar in regard to age, and in both arms we can notice a male predominance. It's almost more than half of patients in each arm having either permanent or persistent atrial fibrillation. With regard to comorbids, almost comparable percentage in both arms, and there is no major differences. As we mentioned, majority of patients were having some sort of anticoagulation, either vitamin K antagonist or direct oral anticoagulation prior to surgical intervention. And most of the patients were having some sort of valvular procedure, with almost 65% in the occlusion group and 67% in the no occlusion group. Concomitant ablation for for atrial fibrillation was performed in 34% and 31% in the occlusion group and no occlusion group, respectively. And with regard to the common procedure for occlusion used, most of patients underwent cut and sew procedure with 55.7%, and remaining less patients used either closure from within the atrium or closure device. This table showing the long-term adherence and on anticoagulation on the follow-up, and we can notice at discharge, majority of patients were on vitamin K antagonist, and later on at 3 years evaluation, the percentage was equally divided between either vitamin K or direct anticoagulation. That indicates the reason for either presence of a valve or not. With regard to the primary and secondary outcome results, from this table, we can see that the composite outcome of the primary, composite incidence of the primary outcome was statistically significant, with a lower incidence in the occlusion group, with a hazard ratio of 0.6 and a confidence interval between 0.5 to 0.8, giving a p-value of less than 0.001. But if we looked at each one of these primary outcomes in separate, we'll see that systemic embolism alone does not show a statistically significant difference between two arms. And another important point is that within the first 30 days after surgery, there was no statistical significance in terms of incidence of ischemic stroke or systemic embolism, with a hazard ratio of 0.8 and a confidence interval of 0.5 to 1.1. While after 30 days comes the difference to be noticed, with a significant p-value and a hazard ratio of 0.5 and confidence interval of 0.4 to 0.8. And this is being proven and shown in the Kaplan-Meier curve here. Initially, there is no difference between the two groups, and with the long-term run, we can notice the separation of two lines, with more incidence of ischemic or systemic embolism in the no occlusion arm, and this is a magnified picture with hazard ratio. An additional analysis has been done to test the effect of left atrial appendage across subgroups, and it shows a consistent result. We can see here in a subgroup of either based on the sex or age of the patient, an important finding in here that patients who were at baseline on oral anticoagulation, direct oral anticoagulation, has benefit more with occlusion group with the occlusion than no occlusion in comparison to patients who were on vitamin K antagonist. Another thing, that patient with a very high VAS score, more than 4, showing no significant difference between occlusion and no occlusion group. And in terms of ablation of atrial fibrillation, whether those patients underwent ablation or not, always the occlusion is a better outcome with regard to no occlusion group. And here at the end of the same table, it shows that overall the occlusion group has a better outcome with regard to the incidence of stroke or systemic embolism. So as a conclusion and discussion, in this trial, among the participants with atrial fibrillation and risk factors for stroke, the risk of a composite outcome of ischemic stroke or systemic thromboembolism was lower with a concomitant left atrial appendage occlusion. And the number needed to undergo concomitant occlusion during cardiac surgery to prevent one stroke over a period of 5 years was 37, with a quite wide confidence interval between 22 to 111. It has been hypothesized that removal of the appendage as it's the source for production secretion of atrial natriuretic peptide would result in impairment of clearance of salt and water, and thereby increasing the risk of heart failure. But in this trial, the incidence of heart failure was not observed, and there was no increased hospitalization or new hospitalization for heart failure during the follow-up period of the study. Surgical occlusion of left atrial appendage proven to reduce risk of stroke, and it usually does so by a different mean than the oral anticoagulation, as its effect appears to be more continuous and permanent. And this addresses some of the limitation of the anticoagulation use, as we said, non-adherence and discontinuation. And they have observed that a higher rate of stroke, as we said, in the first 30 years after surgery, as compared with the rest of the follow-up. And this might be due to surgically related to the procedure itself, either from manipulation of the aorta during cross-clamping or other reason, rather than the atrial fibrillation itself, and for which the occlusion will not play a role in preventing such a risk factor. And whereas anticoagulation reduces the risk of stroke approximately by 2/3, in this study, they showed that a concomitant occlusion of the left atrial appendage would reduce the risk of stroke by approximately 1/3. And this might be related to the increased risk of stroke related to hemorrhagic stroke related to anticoagulation use. So as a conclusion in this trial, they showed that surgical occlusion of the left atrial appendage provided additional protection against stroke when added to anticoagulation, not as a standalone prevention measure. Limitation of such a study, this study, first is lack of information about the relative efficacy of left atrial appendage occlusion in comparison to oral anticoagulation, as we said, because they did not test the procedure as a standalone preventive measure in comparison to oral anticoagulation. So we cannot conclude this could be a standalone preventive measure, an effective preventive measure, but rather an additive measure to prevent stroke with anticoagulation. Second, we cannot discern from the results whether all surgical methods for closure of the appendage are comparable, as they do not examine whether occlusion were, as well as they did not examine if the occlusion was sustained over the follow-up period. In addition to that, they did not include the percutaneous endovascular occlusion device, as it's one of the available measures for occlusion of the appendage that might be effective, even though some might hypothesize that using an endovascular measure might predispose for thrombus formation and embolization and stroke risk. That's it, and if there is any question.
Thank you, Mohammed. Dr. Farid, any comment from your side?
Well, I guess the best person to ask about this appraisal is Dr. Hussein Ghatan. But my comment is that what I saw in the last in the presentation is basically a review of a published article. It's good. It's a good review. You have illustrated all the points related to this article and the steps they've taken and the analysis, and you came up with the basically a good understanding. The question is always, is this a good study? Is it influenced? Does it have any bias areas that you should be concerned of? And if that's the case, which population should you apply these results to? Will it affect your own practice, or how you will it change your practice with those patients? Is this recommendation valid, basically? So when you are looking at the journal club, we're not just aiming for reporting the study, the details of the study. We should dig and find out and have a critical appraisal of that particular study. In this case, it's a randomized clinical trial. And there's a format that you can use for this with a set of questions. I'm not sure if Dr. Haytham Al-Bar is also there. Those two people, Hussein and Haytham, have elaborated a lot in the past, and I think you can learn quite a bit from them. Thank you.
Thank you. Dr. Hussein, any comment?
Thank you. Nice presentation. I would like to see comparison between this study and other study done, and the result will be different or not. And as Dr. Farid said, it's worth to apply this study on our population or not. And sometimes it's helpful to go to some website and download the format, like a consort format, and go one by one. See what's significant and just mention the significant thing. What's the strongest point or strongest association with the study you mentioned, and the weakness of this study. And there is any bias of this study in general. You have to mention 3 or 4 type of bias, and you say there is no bias in randomization, no bias in informed consent, no bias in the result. Sometimes there is difficult to comment about the statistic. So what you should do, go to the website and see other comment about the study. What's the critique they put on the study? Some biostatistician, they critique the study in that point only, or the type of or the comment of reviewer. So just read the comment and go back to the study and analyze it more. But it's nice review. Thank you.
Thank you, Dr. Farid and Dr. Hussein. Mohammed, thank you very much for your presentation. So by this, we'll end our session for today. Thank you.